Welcome to another Tuesday VMR. Today we have here Ravi, and we are going to be discussing a case presented by Shiria. We are really excited. And I just want to remind everyone if you're applying for the match, we did Saturday our mock interview episode. It's in our YouTube. So check it out. It's really helpful, and we were really excited to do it for 5 years in a row. Ravi, how are you?
Absolutely wonderful. Very happy to be here. Also, very excited to discuss with Deborah, who's been a long time colleague on CPS. So when did we have some CPS boot camps back in the day? When was that? 3, 4 years ago, I think.
I think
So
3, 4 years ago.
yeah, so no Deborah from a long time. So very excited that she's jumped into the discussion seat and excited for the case presented today. So we'll have Shreya unmute and introduce herself. Go ahead, Shreya.
Sure. Hi, everyone. I'm Shreya Upadhyay. I'm a medical graduate from Nepal. I'm currently in St. Louis, and I'll be sharing a case with you all, and I'm looking forward for the discussion.
Absolutely wonderful. And then behind the scenes, we're going to have Eugene and Julia helping with scribing and teaching points. Eugene, how are you?
Hello, Dr. Ravi. I'm doing well. I hope you're also fine. I'm Eugene from Ghana, and I'll be doing the teaching points today.
Awesome. And Julia, how are you doing?
Hi everyone, I'm Julia. Excited for Sharia's case and Ravi and Deb discussion.
All right, let's get started with some learning. If you can bring the whiteboard up, and Shreya, if you have the first aliquot.
Sure. So we have a 62-year-old male presenting to our emergency department with worsening shortness of breath for 15 days. And I'm going to take a break now and see what you guys think.
Very interesting start. What do you think, Deborah? 15 days. That's quite a long time.
It is. I think shortness of breath, it's one of my favorites. Chief complying, and the first thing that I noticed is like for 15 days. So I'm wondering why the patient is looking for help now. Like, what if that is getting worse with time, and if he has any additional symptoms, like if he has any cough, any chest pain or something that made him looking for the emergency for looking for some doctor right now. And yeah, of course, with this age, I'm worried like with some heart failure or if he has any smoke history, any like COPD, asthma, um, and maybe like we can look like for some malignancy. I don't like to start the first aliquot with a lot of diagnosis. I like to first realize and look for what we are dealing with. So yeah, definitely look for ask more questions for the patients to see how is he feeling, why, and he's looking for the emergency department. Go for the buckets that we have, like for shortness of breath of heart or lung, or it can be some anemia, some acidosis and anxiety. And yeah, and try to see how is the patient saturating. Maybe try to make the patient walk and see if the patient is having any symptoms. I think I can start from there. How about you, Ravi?
Yeah, I love the train of thought that you just presented there. It's very intriguing that yes, at this point, I do not want to sort of jump into major diagnosis, but stand back and think about the systems associated with the respiratory system. So it's the respiratory system itself, and then everything that's adjoining it, and then the control center in the brain. So any one of those systems is fair game. And at this point, you have to sort of run your thinking, your intuition on two tracks. One is what is going on, and then also thinking what testing will really help me, high value testing. So not just randomly getting all the tests and then hoping for one of them to shed light on the diagnosis, but thinking about with breathing, what kind of data will help you to determine primarily the disease that's going on, and then also what could actually eliminate some of the major diagnosis. And sometimes we want to think about what is very dangerous for this patient, right? So we do want to, there's this do not miss diagnosis that we have to think about as well. But we don't need to just dwell on that as well. But at this point, I think we need the background of this patient. Like you said, what if there's asthma, if there's COPD, if there's any social history, any determinants that could potentiate respiratory disease. And then the 15 days at this point, you have to think about what could immediately present with, what kind of conditions could immediately present with shortness of breath. So catastrophic, very sudden occurring features like pneumothorax could have you present with shortness of breath. Acute or hyperacute pulmonary edema and acute ACS could also do that too. I like the thought, maybe thinking about things outside the respiratory system, like anemia. Also, abnormal blood gases we should think about as well. So if you have this very severe acidosis, that could also cause tachypnea. So at this point, I kind of will sit back and then listen to what Shreya has to offer with maybe more medical history and then also some of the past medical history. Any other thoughts, Deborah, before we turn the mic back to Shreya?
No, I think that's it. Shira, can you share more information with us?
Sure. Such a great start and awesome thoughts were put. So I'm going to give some more details. So he had a lot of symptoms going on in a long term. So he had chronic cough since 1 year with insidious onset, and which was gradually being progressed over 1.5 months now with increased amount of mucoid expectoration. And he also had 2 episodes of minimal hemoptysis prior to presentation. And he also had fever for 2 months, which was intermittent, documented at home up to 102 degree Fahrenheit, associated with chills, evening rise of temperature. He also had a loss of appetite, and he also mentioned weight loss. So, but there was no history of night sweats. Since 15 days, he is having difficulty breathing while doing daily activities at home. And he also mentioned that he is having difficulty walking even 100 meters on a level ground. And he used to have mild difficulty breathing since few months now. But he said that it's been progressing and it's hard to do daily activities. So he presented to our emergency department. No history of chest pain, palpitations, orthopnea, PND, no history of pedal edema, jaundice, hematomesis, no history of oliguria, burning micturition, headache, or seizures. So in past, he has a history of COPD and type 2 diabetes mellitus with non-proliferative diabetic retinopathy. And he also has hypertension and coronary artery disease. For this, he used to take tiotropium, metformin, and amlodipine. He has no drug allergy. He is a chronic smoker, and he mentioned that his appetite has been reduced recently, and his COVID vaccination status was 2 doses of vaccine was given recently. So in social history, he is from Nepal, and he used to work as a farmer, and now he says that he can't work because he feels too weak, and his wife and son has been taking care of him. So I'm gonna stop here and listen to your thoughts.
Well, Shreya, a lot to share there. So now we have to unpack some of this data. So what we have to do is then pick apart the key features and what really stuck out to me, the fever and then the cough. So the cough itself to me means we're in the domain or in the space of the respiratory system. Why exactly, if you think with this patient, why are you having cough? The essential elements for a cough, why does the body cough in certain situations? It's a well-coordinated reflex arc going through receptors in the lung, and you have receptors which primarily is through cranial nerve 10, the vagal nerve, and then you got phrenic nerve, trigeminal nerve. So you have a number of nerves, and then the center is within the medulla. And there's certain receptors within the airway. I kind of asked, like, why exactly would you have a cough? And then this is the system through which you have cough. And then within the lungs, if you think about it, there's certain irritant secretions or material that needs to be moved if it obstructs the airway. Certain inflammation can also irritate these nerve fibers. So you have certain irritant receptors, you have C receptor fibers, and you may also have mechanoreceptors, which, if signaled, can also result in cough itself. So we know along the respiratory pathway, there could be some obstruction, there could be some secretion, there could be foreign body, inflammation, anything that could be irritating any of these different nerves and producing cough. Although we should also think about the other nerves, so vagal nerve, phrenic nerve, and then trigeminal nerve. So phrenic nerve is the diaphragm also being irritated as well. With fever, you bring fever into that, and this is a signal likely for maybe something infectious. Can't really say at this point bacterial or viral, and viral respiratory infections are probably the most common. But with the fever, the likelihood or the predisposed probability for infection is very high / inflammation. So imaging will be key here. Remember earlier on I mentioned we need to operate on two tracks. One is what likely is going on, and then what is the testing to propel the diagnosis forward. So imaging will be key since we're in the space of the respiratory system, upper respiratory, low respiratory, one of these. Now, expectoration, there's sputum, and sputum is propelled from any part of the respiratory system there as well. So this is productive. Does productive cough increase the likelihood for infection? Probably not. I mean, there could be material that's in there, and again, we if you go through what kind of material, sputum could be from infectious, it could be sputum that's impacted there, could be a tumor that is impairing the amount of mucus that's being cleared. So there's so many different things that it could indicate, but it doesn't really give you enough material to indicate infection at this point. But the fever is very, very suspicious at this point. This is very impactful presentation because the patient now can't function as they were. So this is very, very, what are you saying? Life impairing or quality of life impairing, which is alarming at this point. But I'll turn the mic over to Deborah to maybe elaborate on the other parts of this or background of this case.
Thank you, Ravi. Yeah, such a lot of details here. So I think you talk a little bit about the cough and fever, and then like about the hemoptysis. Like normally I try to think like how much was the hemoptysis, and I think that is something difficult like to establish. Like if the patient probably had a lot of hemoptysis, like he would tell you and probably being scared or something like that. So how is something that we cannot measure. I try to see how is the patient feeling, like if the patient is by his physical exam and his vitals, you can see like how serious that could be. And we have a lot of symptoms here, and I think like I learned something from Jack, like that we can see there's some inflammation, and we can go like for big buckets, like if there's a malignancy, an infection, or an autoimmune. And I think like in this case, I would go more for something like an infection or a malignancy. The patient had like a COPD, he's a smoker, definitely we can think about a malignancy, it could be a cancer, or it could be a infection with that exacerbated the COPD, like it could be a pneumonia, a TB, and thinking about like his environment as a farmer, if any disseminated fungus, brucella too. So Yeah, I think now we have a lot of things going on, and definitely looking for the vitals to see how is the patient saturating, how is his respiratory rate, and examine the lung, and I think start with chest X-ray. What do you think, Ravi?
Yeah, absolutely. This inflammation or this domain of inflammation that you mentioned is very intriguing, I would say, at this point. And because this isn't anything I could suggest be cardiac or that kind of wouldn't be chronic in this, like you put up this schema of chronic cough. It kind of would ramp up or get worse, right? You're filling your alveolar with pulmonedema, and that it wouldn't last 2 weeks. Or keep the patient out of the hospital. Although what's interesting with heart failure, you could have a low-grade fever. It is an inflammatory process with a neurohumoral cascade that you get of the hormones that are involved with heart failure. But here, there's a lot of features which scream inflammation, especially this loss of appetite and weight. So a lot of times we think about sort of a reflex thinking, loss of appetite, weight. This could be malignancy, but you could have, like you mentioned, these chronic infections that could fester for a while and slowly ramp up and be insidious. So, and then the background, which is very interesting as well, he's a farmer. And now you think about what kind of farmers. I live around farms, and there's certain farms where you're exposed to animals. So, like you said, Brucella comes to mind, and all the soil-borne organisms that you think about, endemic mycosis, right? They come out of the ground. If you're in California, you have, or out west, you have coccidiomycosis, right? That's valley fever is quite prominent there. If you go up to Ohio River Valley, but it could also be towards the Midwest as well. Histoplasmosis may be endemic there as well. So there's certain organisms that you may find within the soil, and farmers, what they do, they till the soil, and that's how they earn their livelihood, and also then are involved with livestock, and certain conditions could emanate from them as well. I had a farmer once that had cats, dogs, rabbits, everything bit him. He drank unpasteurized milk, and he ended up having cat scratch disease, so Bartonella. So that's something I would have to look at. And the exam I'm very intrigued about to see if there's any sort of involvement with contact with animals, and something that the farmer could have had or obtained from that. The other thing is, what if it's a hypersensitive pneumonitis? If it's a inflammation of the lung from being around hay and other things that they cultivate. So a lot to sort of think about, but we'll move on to the exam, and maybe we do breakout rooms. We have time for breakout rooms since we have a large number of people. We'll swing the mic back to Shreya.
Awesome discussion. I love the broad differentials. So we have physical exam. So the general examination, patient has poor body habitus. He looks pale and he has grade 2 clubbing. He has temperature of 100 degree Fahrenheit, respiratory rate 32 per minute, heart rate was 104 per minute, and BP 122 by 78. And his saturation was 94% in room air. So CVS examination was S1, S2 heard, no murmur. From head to toe examination, abdominal examination, CNS and MSK all were normal. In pulmonary examination, bilateral air entry, normal vesicular breath sounds with expiratory wheezes, with bilateral infrascapular and infraaxillary crypts, left more than right. These are the examination, and I would like to know what you think and what labs would you want to order.
What do you think, Deborah?
I'm catching it with the whiteboard. Yeah, like I think the patient has 100 Fahrenheit, so a fever. I don't know how much is that in Celsius, and 94% on room air. Even like that, we expect a little bit more. This patient has COPD, so I don't think like we can try to like I think we probably try to put like some oxygen on this patient, but I would be worried like we cannot put too much in patients with COPD. And the patient has some wheezing and crampness. So definitely the wheezing, like sometimes we always think about asthma, but can be a presentation like the COPD. And he has like some cramps that make me think it could be like a pneumonia. So yeah, I think like this physical exam is just like reassuring what we were thinking about the history, and the patient has like uh, the clumping that make me think first diagnosis of a cancer, but can be from the COPD too. So yeah, definitely I think looking for some labs, see if the patients that can smoke for a long time can have some polycythemia, see how is his blood gases, and some chest X-ray, and the WBC if he has any neutrophils or eosinophils where we can think about an infection. What do you think, Ravi?
Yeah, absolutely wonderful breaking down of the various key parts of this exam. Yeah, this the clubbing is interesting. There looks like there's some chronic pulmonary disorder, and the mechanism there, like you have chronic lung disease, and certain cells get filtered, like macrophages get filtered by the pulmonary circulation, but they escape it because of the chronic lung disease and end up having growth factor released, causing the distal clubbing, um, which is one mechanism. There are a couple other mechanisms as well. So there's clearly something that's been brewing for quite some time. What exactly is that? I think imaging will be crucial in this case to figure out if there's something like in the background, like chronic lung disease, hypersensitivity pneumonitis we talked about. I mean, definitely X-ray and maybe high resolution CT if we do find any hallmarks of ILD on the X-ray. Infection also likely in this case. So the patient's been smoking for quite some time. There could be a background. There's this COPD. And on top of that, something else that's brewing. So definitely, I think imaging and then CBC chemistry at this point. And if the CBC indicates elevated white cell count, then doing an infectious workup, so sputum and then blood cultures will be crucial at this point. Would it be necessary at this point to start antibodies? Commonly with a lot of ILDs, there's a overlap of possible infections. He has lungs that have a tendency to develop infections because a lot of the infections come from the upper respiratory tract, the nasopharyngeal, and this oropharyngeal area. All the commensura organisms that are there tend to drop down. So microaspiration can happen. But when you have COPD and you have long-term smoking, all the protective mechanisms lining there where you're not there. So it's very easy for bacteria then to just drop down and cause a pneumonia. So pneumonia is still in the running for this case. I think, should we go on to labs and then we could pause for breakout rooms and then see what people have to say?
Awesome discussion. So I'm going to give some labs. So hemoglobin was 10.5, WBC 5.7, neutrophil 69, lymphocyte 24. Platelet was 24,000. BUN was 101, creatinine 1.9, sodium 138, potassium 4.6, calcium 8.8, phosphate 3.3, uric acid 110, total bilirubin 0.64, direct 0.2, AST 55, ALT 83, ALP 366, GGT 57. Total protein was 5.6, albumin was 2.3, INR was 1.49. HbA1c was 6.5%. And we also had TSH, which was 2.77. So I don't have ECG picture, so I'm gonna dictate the ECG findings. ECG was sinus tachycardia, with right bundle branch block and T-wave inversion in all leads. Retic count was 1.52% and urinalysis was normal. And I'm going to stop here and listen to your thoughts.
Okay, wonderful. I think it's 11:30. Let's pause and do some mini breakout rooms and see what the group or the chat group has to say. So Zoom. All right, welcome back, everybody. I guess before we dive into the case, let's hear from a couple of the breakout rooms. So breakout room 1, we had Manaswini, Regine, Himun. Any one of you would like to share what you're thinking?
We had a lot of great thoughts. I don't know if Winnie, I don't know. Sorry if I said wrong. Do you want to share our thoughts?
Hi everyone. Hello Deborah. Yeah, you pronounced it right. So I was thinking of in the lines of we see that there is anemia and low platelets. So something in the lines of hemolytic anemia and thrombocytopenia, probably ITP due to an infection in probably TB or could be brucella as discussed. And I was also thinking of, since it's a chronic cough, in the lines of bronchiectasis, but we also had great thoughts on the group where we still keep the possibility of aspergillosis open and hypersensitivity pneumonitis as well. I was hoping to get, we were hoping to get a LD, get LDL or Coombs test and the HRCT to identify what the patient might have.
Absolutely
Thank
wonderful.
you.
Yeah,
Would love to hear.
great thoughts there. Yeah, and I'll call on I guess another room. Jillian and Johan were in room 6. Any input or anything that else you want to add to this discussion?
Yeah, so I mean, we basically try to frame, frame the situation. So here we have a patient with chronic cough and systemic symptoms in TB endemic region. So, I mean, first on the differential, of course, TB. There's certainly a component of COPD, sorry, in it as well. So, but it cannot just be COPD, bronchogenic carcinoma and other malignancies. And as you said, and other people in the chat said, fungal infection and other infection that are, common in farmers. And a part of that, the thrombocytopenia, as she just said, well, certainly ITP, we're also thinking about ITP here, maybe in the context of malignancy. So yeah, still have a lot of things on our differential, but that's what we're able to come up with. What do you think, Jillian?
Yeah, I think you summarized everything great.
Awesome, wonderful, everybody. Thanks for your input. Listening to you, it highlighted a few features for me with this case. And what do you think, Deborah? You were in room 1. Anything else you'd like to add before we do a deeper dive into this case?
No, I think the thing that bring up our attention a lot was these platelets that are really low. So Eugene said maybe he would repeat the labs, and I think it's a good idea. Like this patient had some hemoptysis and he's really sick. Could that be the reason about the platelets being low or something else? And then the patient had anemia, so definitely looking for if could be the things that cross my mind right away. It's like if it's an iron deficiency or if it could be like anemia of the chronic disease. So definitely look for some iron, see the ferritin, epsidine to see how is the patient doing. But yeah, I think that was our thoughts. What do you think about this?
So Yeah, it's interesting. The narrative that's been building for this case has been an infection. If you look at the or inflammation, the X-ray shows there's something going on in the airspace, right? Which accounts for the symptoms. I would look for a more marked O2 sat drop in this patient. 94% on room A is not too terrible. So oxygen or gaseous exchange is not terribly impaired at this point. Although respiratory rate is high, right? So the patient's working hard to breathe, compensating at this point, is tachycardic, has a fever. So that may account for this as well. The EKG is interesting. If we had an old EKG and these findings of right bundle branch block, T-wave inversions, if these were new, you could start thinking about also something like pulmonary hypertension, which the patient may have had. And sometimes these could be a signature of pulmonary embolism if this is new. So, however, maybe we are dealing with a sandwich case here of several different things, not just one unifying diagnosis, but maybe several things. So sometimes, say, you have malignancy, which causes downstream respiratory conditions, downstream anemia from diffuse alveolar hemorrhage and hemoptysis, which causes, and then the malignancy causes downstream effects like pulmonary embolism. Maybe we're dealing with something like that here. And the hemoglobin, not too terribly low, but the platelets, what's going on with the platelets? So you have to start thinking with basics. Why would the platelets be low in this case? Either you're consuming them and you're bleeding and the bleed doesn't stop, so you're just making clots. However, you cannot close the source of bleeding. The other thing would be, is it a bone marrow issue where you're not making bone marrows, or you're destroying the platelets, sort of like an immunological process, or like ITP, Evans syndrome, and so on, TTP. So, or it could be DIC as well in this case. But yeah, so here at this point, I think further testing, people mentioned doing an immune workup for autoimmune hemolytic anemia, LDH, looking at haptoglobin, looking at peripheral smear, just to make sure. You know what bothers me though? Normal retic count. So if you have a hemolytic syndrome, hemorrhagic condition, your retic count should be high. If your retic count is low, this is a bone marrow issue. Here it's normal. So the response is not appropriate. So they could be dual processes that are happening at the same time. So remember we talked about infections. So certain infections could affect both bone marrow and also in the peripheral, um, um, I guess, hematological process as well. So at this point, I think with this X-ray, we do need more detail or definition. So getting a high resolution CT will be important to see what exactly are these opacifications, and also doing more testing, hematological testing, I think will be imperative at this point. Anything else, Deborah, that would you get? Okay, we'll turn the mic over to Shreya.
Awesome discussion. So I'm going to share the chest X-ray now. I'm going to start sharing. 1 second. Can you see my screen?
Yes.
Oh yeah, what do you guys think?
We can see there's a lot of infiltrates on the lung of the patient. I see on both lungs. We can see like our aorta. It's really like calcificated. We can really see we call it in Spanish the bottom, and definitely like some consolidations too. I don't think the heart looks really big. What do you think? I see the costophrenical angle, so I don't think there's any fusion. What do you think, Ravi?
Yeah, I think wonderful job. Yeah, they're The left side, I agree that I don't see an effusion. First of all, just looking at this, the lungs, they don't have that nice sort of tapering conical at the top, at the apex, normal X-ray configuration, right? This is just large, boggy lungs. So this is clearly like emphysematous lungs, if we look at that. If you had a lateral too, you would see then obliteration of the retrosternal the retrosternal process as well. Or no, actually, you would develop the sternum lifting off the heart as well, because the sternum is right against the heart too. So emphysema would be more boggy in hyperinflated lungs, which you see here. And then on the right costophrenic angle, it looks like there could be an effusion. And usually the right dome of the diaphragm is 2 centimeters higher than the left there, so it is higher. And if it was really high, in this case, you would worry about volume loss, so atelectasis, but here it's appropriate. But it's got this sort of little bit of meniscus sign, so there may be a effusion there as well. And is a patient rotated? Maybe a little bit, but the heart isn't enlarged, but it's sort of more towards the left, but there is a little rotation. Looking at the lungs itself, if you look there are some exaggerated lung markings on the right side and the lower right side. So if you look in the middle lobe around there could be some lung markings. I think this definitely would call for a CT to get more definition. I think behind the heart, you can see lung markings behind the heart, so there's no retrocardiac process there. And below the diaphragm, you see on the left side the gastric bubble. So yeah, I think I don't see a pure opacification, but there's something going on the right side there. Any other thoughts, Deborah?
No, excited to hear more from Shira.
All right, back to you, Shreya.
Yeah, so the chest X-ray showed bilateral heterogeneous opacities. We could see some small nodular opacities as well, which is very negligible, in very negligible way. So HRCT was ordered, and it took some time, and sputum cultures were ordered as well. And in the meantime, patient was started with levofloxacin, pantoprazole, and inhaled bronchodilators. And so COVID came back negative, and USG abdomen showed mild splenomegaly. And peripheral blood smear was done as well, which showed normocytic, normochromic, and with low platelets and no abnormal cells. So the patient was, hematology consult was sought, and patient was advised for bone marrow biopsy, and the patient refused it, so it was not done. And so we have HRCT thorax next. I'm going to start sharing it now. Yeah. Can you see it?
Yep, we see. Wow. What do you think, Deborah?
The first thing when I saw this was like if it could be a disseminated TB, like a miliar. It's how we say in Spanish. I think the same in English. Am I right, Robbie? Miliar? Okay.
Correct.
Definitely was the first thought that came to my mind, that is this disseminated the TB. And we can see like the vessels are really like enlarged, and we see the nodules that we saw in the chest X-ray, like the diffuse nodular opacities. I don't know. I don't see any grand glass opacity. I think that's are my thoughts. What about you, Ravi?
Yeah, it's very apparent in this on the CT. It's just the alveoli just diffusely just involved with this small seed-like manifestation. And what comes to mind is this miliary TB, which was one of the hypotheses that we initially had entertained in the beginning of this case. So it does fit the picture. You know what's interesting? Like thinking, going back, Ebby, who does come on to many of these VMRs, always has some interesting input on these cases. She had mentioned, what about this hyperuricemia? So I got to thinking, like, what would hyperuricemia, what would this signify? Could that be sort of like the smoking gun? Probably not, but it does increase the likelihood of certain conditions, right? So here, definitely, I think miliary pattern, although in the x-ray, most of the x-rays, whenever we do TB lectures and so on, we show the x-ray and it has a miliary sort of manifestation. I would do a quick check of what miliary-like conditions in the lung, but I didn't see it. I guess Shreya did notice it was likely the penetration of the x-ray, but she did say there were little small nodules that were seen. So like she was mentioning this, but here is very apparent. And if you think about why is the uric acid increase in this case, so immediately knee-jerk reflex would be something like tumor lysis syndrome, so increased cell turnover. And what's interesting, hyperuricemia is associated with two infectious conditions. So one would be brucellosis, although the hallmark of that wouldn't be this kind of manifestation in the lung, and then TB, although I don't think it has a certain affinity for a condition like miliary TB here. So this does increase the suspicion for TB in this case. What do you think you would do? So when you think about testing, there's certain tests that are for active or latent TB. If you remember, Deborah, what test would you do, since it appears this patient is in the active throes of tuberculosis, if that is the case?
I think we can definitely try to do a sputum, like to see if there's Nielsen, to see if we'll grow up, and I think like some gene expert.
Absolutely, yeah. So with the latent, you would do the usual tuberculin skin test. You will do the quantiferon gold. And for active, you would do the 3-AFB smears. You would do culture, which usually takes a long time. The gene expert or the NAT amplification test you would do there in this case. So definitely one of those tests will be likely necessary in this case to at least rule in TB or rule out TB and start moving on to the other possible diagnosis. I'll turn the mic back over to Shreya to see if she has any of this data for us.
Yeah, great thoughts. So yeah, you guys are right. So there was diffuse small nodular opacities with some reticular opacities as well, as you can see. And the chest X-ray was very vague. We could not notify the small nodular opacities, but here you can see it's like showering the nodular opacities. And so yeah, the patient, the CT findings was small diffuse nodules with reticular opacities. So, yeah. So, so the sputum culture came back and it showed MRSA, and AFB was negative. So, so the patient was sent sputum CB-NAT, and Mycobacterium tuberculosis was detected, and patient was started on ATT. But patient suffered drug-induced liver injury and acute kidney injury as well. So the ATT regimen has to be stopped and switched to SLE regimen, streptomycin, levofloxacin, and ethambutol with pyridoxine. So, and patient improved over time, and platelet counts were improved as well. So though the bone marrow biopsy was not done, we were thinking that maybe the miliary TB was affecting bone marrow as well, and the treatment kind of improved the platelet counts. So the patient was hemodynamically stable and was discharged on request. So the diagnosis is, and yeah, patient had MRSA. So So patient was on empiric antibiotic before, and then patient during the hospital stay, patient also had Acinetobacter, hospital-acquired pneumonia with Acinetobacter baumannii. And so the case, hospital course was quite complicated for the patient and was very unfortunate. But patient improved gradually, and cholestyramine was given, and else. So yeah, and so patient had also stopped taking medications for his hypertension, diabetes, COPD in a while, and so he was started with aspirin, statin, amlodipine, and yeah, patient improved with all those in treatment, and he was discharged on request. So the diagnosis was miliary TB with superimposed community-acquired pneumonia.
Wow, Shreya, very, very unusually presenting case and very well presented. I really appreciate you putting this case together and spending your time. So I didn't expect TB again. TB, one of the great mimickers, is just fascinating how it can present. I was all in on the farmer and maybe HSP or something from one of the animals, but TB could fester there for so long. And this has the kind of narrative, an insidious infection, long-standing, being sick, and just remarkable education. You taught us a lot and fantastic images. So really appreciate you for bringing this. Deborah, any reflections?
Yeah, thank you so much, Shira. I really like the presentation, and like unfortunately the patient had like some drug reaction, no, on the liver and the kidney. So I'm glad that you're taking care of the patient and switch the medication. Yeah, learned a lot. Thank you so much, Ravi. Eugene, do you wanna come with the teaching points?
Okay, so I'll be very brief. So we had a patient that started in with cough and then, shortness of breath. And we had to decipher what could be the cause of the shortness of breath. So we were first taken through that by Deborah to consider the duration because that can actually help you to see the severity of the shortness of breath. So acute versus chronic. And then anatomical areas to consider included the lungs, the heart, and even the blood, because you could have some metabolic issues and then anemia as well. And then she taught us also to rule danger signs. And so you're looking at the SpO2 respiratory rate, and then with the SpO2, you're able to tell whether there is some form of hypoxia. And then Dr. Ravi also told us to consider the background as a past medical history to guide us to be able to localize if it's the lungs or the heart, and then also the context with physical examination and some labs and imaging. And we got some associated symptoms and background information where this patient also had a cough. And so Dr. Ravi took us through what it means by a cough, which is basically an airway protective reflex. So he mentioned some nerves that are involved in the cough reflex, and so with the afferent and efferent pathway. So the vagus was send in and then processed by the medulla and the trigeminal, and then also the cranial and diglosopharyngeal. And he also mentioned that we shouldn't forget about the phrenic nerve, which is where when you have an irritation with the diaphragm, you can actually also have cough. And then he talked about fever, where we could consider an inflammatory process or infectious process, malignant or autoimmune, to be the cause of the fever. But we tried to link it up with other background information in this patient, where the patient was a chronic smoker, had a previous COPD, and also a farmer. So we started thinking about soil-borne organisms that could be translated into the chest and cause some form of pneumoconiosis or hypersensitivity reaction in the chest. So we talked about Brucella endemic mycosis, and then we thought too that any form of hypersensitivity pneumonitis can actually manifest in this particular form. Then we had some exams finding the patient was wheezing and then had some crepes in the chest, and yeah, also had some grade 2 clubbing. So Dr. Ravi took us a bit through the pathophysiology of clubbing, mentioned one part, which is when there is a chronic inflammatory conditioning. I didn't really get that side very well. He mentioned something about macrophages being the cause of growth factor production, and then that will lead to clubbing. And then he talked about what we would need to actually clinch this case will be imaging. But we got some labs which brought a breakout room. Interestingly, we saw anemia and then thrombocytopenia. So we started thinking about what could be the causes of anemia and thrombocytopenia. And our thought process was that could this be as a result of just peripheral distraction, since the patient had also had hemoptysis, or could this be at the level of the bone marrow, where there's a bone marrow suppression? And so Dr. Ravi mentioned that we can do some labs. Also, Deborah added to that we can do some labs and then rule out hemolysis. Also, he mentioned that so when you have somebody with a marrow suppression, usually the rectal count should be low, but if the rectal count is normal, then you're thinking that maybe the bone marrow is trying to compensate it, but it's not compensating quickly. So there's some form of peripheral distraction as well. So you could rule out hemolysis, you could rule out autoimmune causes, you could rule out a consumptive process like sepsis, DIC. And then he mentioned something about the hyperuricemia, that there could be indirect causes. TB, microtuberculosis, and then brucella could be indirect causes of the hyperuricemia. Then our chest X-ray showed a reticulonodular pattern, which pointed to miliary tuberculosis. And then Dr. Ravi mentioned some pearls where if you have latent TB, you can do the IGRA, that's interferon gamma test, or quantiferon gold test, and then the TST to actually be able to capture latent TB. But if it's in the active phase, then you are doing your acid fast bacillus, and then the test that we did that clinched the diagnosis. So this was a case of a miliary TB packed with a lot of rich learning for all of us. And so this is where I'll put my teaching points. Thank you.
Yo, Eugene, great teaching points. Very organized and pragmatic, and you really added some of your expertise to this. I really appreciate that. It was like you delivered a lecture on miliary TB. Wonderful job. Wonderful job, Shreya. Very nice case, very well presented. Please do come back again and bring more cases if you have some. And Deborah, wonderful discussion. Pulmonary case, which is an area of interest for you. So we got to read some nice x-rays, and this CT is just like, I mean, it exemplifies miliary TB. So thank you for your input and coming on today and discussing. Take care, everybody. Have a wonderful Tuesday. Bye.
Bye-bye.